of you are doing your own scans? Almost everybody is doing their own scans. Good. So it's just an extension of our right hand. That's what I feel, because it gives you an idea of what you're doing, what decisions to make. Without scanning, I'm totally handicapped as far as I'm concerned. I make almost all my decisions based on doing a scan, even if it's gynec, abdomen, or obstetrics. So this is it. Changes the okay, next time. So this is a lovely picture of a baby with an open hand where you can, because there's always been a debate saying whether we have to count the digits or not. But nowadays with higher end machines, it's very easy. When the baby is opening and closing its hands, we can almost see all the fingers. Next. So recently we had our Ganesh Chaturthi. This was a lovely art which my colleague had sent, where they have depicted a Ganesha inside the cerebrum, which gives us maybe blessings not to miss any anomalies with high resolution, high end machines. Next one. Actually, this is a beautiful video which is not playing, so we'll go to the next slide. So here, let us go according to the protocol from the head to the toes. So in the cranium, what are the different things that we have to check out so as to not to miss either the forebrain or the posterior fossa anomalies? First of all, we have three planes. One is the transthalamic, transventricular, and the transcerebellar plane. In the transthalamic plane, we go for the measurement of BPD and the BPD and OFT as well as the head circumference. So this is the plane where we get to see the falx cerebri, the cavum septum pellucidum, the thalamus on either side, third ventricle, and in the posterior fossa we look for the vermis, cerebellar peduncles, as well as the smaller structures like the lateral as well as the occipital areas. So this is the area which, if properly mapped, we rule out almost 80% of the anomalies. Next slide. And this is the transventricular which is exactly parallel to the transthalamic plane. So in the transventricular plane, we get to see the lateral ventricle which has the choroid plexus, and if you see it filling almost 3/4 of the lateral ventricle, it means it's normal. If you see a dangling choroid plexus with a lot of the fluid as well as the lateral ventricle empty, then it means something is wrong, or dilatation of the lateral ventricle. Next one. So this is the cavum septum pellucidum. Cavum septum pellucidum, what does it reflect? Why is it important? And what is the size? The size is from 2 mm up to 20 mm. It goes on growing up to 28 weeks. After 28 weeks, it starts shrinking, and by the time of say 38 to 40 weeks, it's around 4.5 to 6 mm. That's all. So that is where we have to be careful to map out whether it is really big or really small, because the natural processes after 28 weeks it starts shrinking. What does it signify? If you see a very big one or a very small one, immediately go for the sagittal, mid-sagittal plane. Even otherwise, you have to map the mid-sagittal plane. That is the neurosonography of the fetus, because you have to see the next one. You have to see the corpus callosum. What is corpus callosum? Corpus callosum is big bundle of fibers, like they go cross each other, connect the right brain to the left brain. Even if there is a small hypoplasia or agenesis, it means there is no coordination between the right brain and the left brain. It will lead to a lot of motor, sensory impairment, as well as complex thinking impairment in the even developmental problems in the fetus. This is a lethal anomaly. We should not miss it, because all these are not compatible with the healthy child. Next one. So this is the most important posterior fossa of the brain. In the posterior fossa, you should be able to see both the cerebellar peduncles as well as the connecting vermis. if there is, I mean, the typical dumbbell shape is missing, or if there is a hole in the center of between the two cerebral peduncles, it means there's something wrong with the vermis, either hypoplasia or agenesis. So always be aware that there's something wrong. The fourth ventricle, if it is dilated, or if there is a communicating canal in between the third ventricle and the cisterna magna, always be careful that the Vermean hypoplasia, which again leads to a lot of coordination as well as motor problems. So in this again you have to go for the mid sagittal plane where you can actually see the vermis and measure the Vermean angle. Next one. So dilatation of the lateral ventricle, is it important? How much is big and how much is small? All of you do markers, is it? All of you do double marker, triple marker? Yes, it has to be done. Especially if the patient comes in the first trimester, see that you get the double marker done, because this is usually associated with genetic problems, chromosomal abnormalities. Even what they say is, if more of it, say lateral dilatation of the ventricle is more than 12 mm, it's okay. But if there is a just a marginal borderline dilatation, say from 1 centimeter up to 1.2 centimeter, then it may be associated with genetic abnormalities. So be careful with lateral ventricle dilatation. Mild variety is supposed to be much more dangerous than the severe variety. Actually, what the book says, up to 15 mm you can wait and watch, but always get a marker done. If possible, if the patient is affordable, go for microarray also. Next one. So this is again the posterior fossa abnormality. In this there is a crash sign, that is when the cerebral peduncles as well as the vermis and the brainstem, they herniate into the foramen magnum, into the spinal cord, because of open spina bifida. There is drainage of the CSF fluid. So all these, there is no space at all in the posterior fossa. The posterior fossa shrinks, becomes very small. So it is known as the crash sign. It also leads to lemon and the banana sign, where the skull shape is because of the herniation of these important structures. It is remodeling of the brain. So all these will tell us that there is something wrong in the posterior fossa. The most important one is the Chiari malformation, and the other is the Dundee-Walker malformation. Next one. Blake spout cyst. Can anybody tell me about Blake spout cyst?
I don't know the exact morphology, but usually it is said to be benign.
Yes.
Not much
It actually looks very scary.
Yeah.
There's a large cyst in the posterior fossa. It looks very scary, but it's just an outpoaching just beneath the cerebellar peduncle. It is a benign condition. Usually not, almost 98% not associated with any neurological deficit in the fetus. So Blake spout cyst, you have to properly identify. Though it looks scary, it is benign. So this is myelocystocele with the posterior tethered. Again, because of the tethered cord, there is pulling of the posterior fossa, and there may be some degree of herniation into the foramen magnum. There is a nice cyst in the lower part of the cord, almost in the lumbosacral area. Next one. So this, we had to abort this baby, and this had a meningomyosine with the cyst. Next one. So next we are coming to the neck. Neck is very important, both anteriorly as well as posteriorly. Look for any swellings, especially the thyroid swelling anteriorly, and posteriorly what do we look for? Yeah, cystic hygroma. That is the nuchal translucency. Look for the thickness of the fluid in the nape of the neck. Next one. I think goiter swellings, in my 30 years of practice, I've seen only 2 cases. Very rare. But still, if at all the baby is giving a nice extended neck, you please look for it. Next one. This we commonly come across, cystic hygroma. So whenever you see there is edema or slight increase in the nuchal translucence, maybe more than 2 mm, so please check for any associated, especially trisomy 21 look for the marker, any associated gut or this one, heart anomalies. In this, it was a very huge one, almost up to 3 mm. Next one. This, it was more than 5.9, means more than 6 mm. So all these are typical clear-cut cases. Only the borderline cases, usually they decrease in the next 15 days. When you check, it will come down. After, I think, if at all the patient comes in the 4th or 5th month, it will not be there at all. It doesn't mean that the baby doesn't have downs. It is just that that is the right time to pick up. 11 to 14 weeks, that is when the CRL is between 45 to 84 mm. That is the right time to pick up this nuchal translucency, because later on it shrinks and it comes back to normal. So if at all the patient has come in the 4th or the 5th month, we will easily miss out this anomaly. That's why get the markers done whenever the patient comes. If the patient comes in the 5th or 6th month, get the quad marker done. If the patient is willing, go for NIPT, which is much more, especially for Down syndrome, it is very specific and sensitive. So go for NIPT. Next one. Same thing, cystic hygroma. Next one. Yes, this is a clear-cut case. Next one. So Downs, it's the commonest, 1 in 1,000 live births. So we should not miss out this one, because it's a difficult thing for both the parents as well as the child. It's better to pick it up as soon as possible. Next one. Yes. Next. So how do we actually look for the nuchal translucency? Go for the exact mid-sagittal section, where in the same section you can see the nasal bone, tip of the nose. In the same section you can see the intracranial translucency. This is the intracranial translucency, which is between the posterior border of the brainstem, and posteriorly you have the 4th ventricle, and this is the nuchal translucency. So in the same section you can see so many important things. That is the nuchal translucency. Next one. So this is the exact mid-sagittal section. Quite difficult when it's a baby which is moving very fast. It's difficult to get this section exactly, but you have to try and get. In the same section you can see the ICT, intracranial translucency, as well as the nuchal translucency, and in the same section you can see the maxilla, that is the palate and the omer. So you can rule out a cleft, posterior cleft or anterior cleft also. Next one. So this was a recent case where there was like almost absence of the nasal bridge. The mid-sagittal section was very, very scary, because absolutely I couldn't see any nose at all. The bridge was very flat faces, but the baby was okay. So look at the parents. The parents were from almost like West Bengal, northeast. So they had this typical almost no nose. That was very scary. I thought something is wrong, most probably Downs, but everything came out. NIPT came out normal. So baby was okay. Next one. So anencephaly, I think almost all gynecologists will have some 10 or 15 cases throughout a lifetime. Yearly some 2 or 3. So definitely for every 10,000 live births, 3 to 4 cases. So this is the commonest. Where there is next one, absence of the cranial wall. The entire cranium, the skull bones which cover the brain, is absent. Brain is exposed to the amniotic fluid. Next one. So frog faces, that's what we see. Bulging eyes, frog faces, that's what we call it. And this is a lethal anomaly, so we have to educate the patient, so that next pregnancy they have to use, this is the commonest open neural tube defect. They have to use methylcobalamin, DHA and folic acid at least 3 months from before they plan their pregnancy, to avoid the next time. Next one. This is an occipital encephalocele. One more very common cranial anomaly. There is herniation of the brain matter from a defect in the posterior, like the occipital bone. This upper portion of the cervical vertebra, sometimes even that may be involved. Next one. So this is like some of them are cystic and some of them are septate, but still all this will have outpoaching of the brain matter. Next one. Next one. So all these are different types of acrania and occipital encephalocele. Next one. Next one. So here again there is some problem with the upper portion of the spine also, along with occipital encephalocele. Next one. most important, how do you see the spine? In what sections you have to see the spine? You have to see a sagittal section, and the skin over the spine is also very important. In some cases, the spine is perfectly normal, at least it looks like that. But skin itself, it will give a clue whether there is a spina bifida, occulta or upper open one. So if there is a breach in the overlying spine, you have to dig deeper and see if there is an opening somewhere. Cervical spine, thoracic and lumbar, and the edge and the end of the where the coccyx ends, no, there should be a slight up tilt. That up tilt should be there to tell you that the entire lower portion of the spine is normal, because that is where most of the spina bifida, occulta, meningocele, sacral agenesis, all these happen at that last minute. So look for that tip, there is up tilt, it means everything is fine. Next one. So these are the different views which we see. Sagittal, that's the coronal. If you have a nice 3D, just put the 3D box and you get an entire picture of the coronal where you can see the ribs as well as the spine. If there is any little problem also, it is clearly seen. And then the transverse for in cases like dysgraphia, where each and every vertebra is seen in the transverse portion. Next one. So this one, diastematenelia. In this we go in the each and every section of the transverse cut section. So to actually see the number, the displacement and all that. Next one. So this is one more dysgraphic spine. Next one. These are different types. This was a part. Next one. This was a part of a what to say? It was a syndromic baby. So this baby had all multiple problems: spine, brain. Sacral agenesis is usually associated with Down syndrome,
GDM.
diabetes, gestational diabetes. In gestational diabetes, make sure you see the tip of the spine. This is where we usually, especially after 8th month, see that the sacrum is well developed or not. Next one. Dystrophic, yes. Next one. This was the almost dried out spine. Next one. The baby had polydactyly. Next one. So this was the baby. There was absolutely like no neck at all. The head was almost fixed to the thoracic portion. The hands and legs were spastic, no movements at all. Rigidly held. There was edema, and even the ears were all crumpled. It was a small, very small dwarf baby. We tried to look for all the syndromes. It looked like some kind of muscle spastic baby. Next one. So next we come to the face. In the face, we look for the orbits, the retronasal triangle, the nose, the nasal alley, if there is any cleft palate or lip, and then the cheeks and the chin for either retrognathia or prognathia and all that. Next one. So this was a recent one, 3rd trimester baby. We could make out this hair lip only in the third trimester, and that too only when I tried to put a 3D box, only then I could see. It was not visible even up to almost 7th, 8th month. It was not visible. I tried to go back and see, nothing was seen. Even the nose and the lips which we had taken, that was perfectly normal. This came only after like 3rd trimester. It was a very subtle thing, but after delivery it looked quite obvious. Next one. So this is a clear-cut case of cleft lip and palate. When there is a clear-cut case of cleft lip palate, we can actually see the openings as something wrong with the nasal alley also. Next one. So this is a clear-cut case. We can clearly see that the palate cleft was also up to the uvula. Next one. So we aborted this baby. Next one. Actually, this sir, you should tell me, sir, whether you people continue the pregnancy or
You can prepare
yeah, we told them.
within 6 weeks.
We told them, but they said no. So we can just depending upon their opinion, we can go ahead with the
But both has to be.
yeah, because we are not supposed to for cleft lip for any which can be correctable disorders. We are not supposed to, but patient says no. Severe club foot also they say no. then I think we have to put the ball in their court, and whatever they decide, we have to do.
They will say everything. They will say I want only male.
So this I always have a doubt, sir, because as soon as we show them, they will look up in the Google. Next day they will come and say, no, we don't want. First day we tell them there is a Smile Association. It will be totally free of cost. But next day they will come and say some 6 to 7 surgeries have to be done, madam. We don't want. So it's always a dilemma whether we have to keep or continue. Even if I say no, they'll go and get it done somewhere outside. Previous. Here there is a clear cut. This is the palate. Here there is a gap. So it means that there is a cleft in the posterior aspect of the palate, not in the anterior or in the center. There is a clear cut cleft in the posterior aspect. So even in the mid trimester, make sure that you see the sagittal section properly. The profile has to be viewed. So here it was a case of posterior cleft. Next. This baby had multiple anomalies. There was something wrong with the spine also. So we went for abortion. When we tried to see, there was a cleft deep down inside. Actually, we had to open the mouth and then put a torch and see. Only we could then see the cleft, but it was there. Next one. There is a soft tissue mass here. Soft tissue mass here. So only in this particular axial section it was visible. In any other section, even the profile, it was not seen. Only in this, that too in the 8th month it was seen. So when we consulted our gurus, they said it most probably is hemangioma. So no need of aborting the baby after delivery. It can be cured. Next one. So that is a small dacryocystocele, blockage of the lacrimal gland duct, which again can be. After delivery, I think they just give a massage and see or clear the duct. That's all. Next one. Now for the heart. In the heart, I am not a specialist regarding fetal echo. I just do all the 6 views. If everything is fine with the 6 views, I am happy. I'll just go on. If there's anything little bit wrong in all the 6 views also, I refer to a radiologist. Next one. So previous one first. So in this almost rules out 98% of the anomalies. So make sure you see this view correctly. In this you have to see all the 4 chambers. The most important, the 2 valves, bicuspid and tricuspid valve, when they are actually moving. And here in the left atrium, you should be able to see both the sides, the pulmonary veins entering, and just beside that there is a aorta. Between the aorta and the left atrium, there should not be any gap. If there is a little bit, say more than 5 mm gap also, it means there is venous abnormality, venous anomaly of the heart. So that is very important. It's a very small point, but if you see that, it means that there is some venous anomaly. And in the right ventricle, you should be able to see the moderator band. And this septum primum should be there to rule out ASD. This is the septum primum. So if that is not there, there is a huge large ASD. If that is there, everything is fine. Even otherwise, if that is there, if there is a small ASD, it can, it closes on its own after birth. You don't have to worry. Next one. So this is the LVOT. LVOT is very important because you have to see the aortoseptal continuity. This is the left ventricle, left ventricular outflow tract. This is the intraventricular septum, and this is the mitral valve that is continuous with the aorto. This is the aortic valve. So this is the aortic valve. So this is the septo-aortic continuity. This is aorto-mitral continuity. If these are good, continuous, it means almost you have ruled out VSD and any problem with the outflow tract. Next one. This is the right ventricular outflow tract. As soon as the right ventricular outflow tract, the pulmonary artery comes out, it branches into right and left pulmonary arteries. So you can make out in this view, we see not only the right ventricular outflow tract, but also aorta as well as the superior vena cava. This is the aorta, this is the superior vena cava. Next one. Pulmonary artery, aorta, superior vena cava. they should be to the left of the spine. Next one. So these are the anomalies. There is ascitic fluid. Next one. That is the heart. In the same baby, we could see pericardial effusion and both the lungs pushed to one side, heart almost occupying the entire thorax. Next one. Here also it's the same thing. Pleural effusion, pericardial effusion, heart pushed to one side. Next one. So when you see both the heart and the stomach in the same view, it is definitely abnormal. You should be able to see either the heart or the stomach. When you sweep from down below towards the thorax, you should see the stomach first, and in the same left side you should be able to see the apex of the heart. When you see them one beside the other, it means they are in the same plane and it's a diaphragmatic hernia. Next one. Here it's clear. You can see the diaphragm here. From there here, diaphragm. The heart is here, stomach is there. They are in the same plane. It means the stomach has herniated from the diaphragmatic opening into the thoracic cavity. It has pushed the heart more to the left side, and if at all it's just the stomach portion or the bowels, it's very easy even after birth to repair this. But if a portion of the liver is also pulled inside, then surgery can be done, but they say the prognosis is not good. Next one. It's the 4-chamber heart. Next one. So what are the things that we see in the Doppler of the heart? In the 4-chamber view, once you switch on the color, you should see the inflows. In the outflow, they should crisscross. That is, the aorta, it comes from the left ventricle, and the pulmonary artery comes from the right ventricle. They both cross each other. If they are like parallel to each other, it means that is transposition of great vessels, which is a part of tetralogy of Fallot and so many other abnormalities of the cardia. Always see if both the outflow tracts, they should cross each other. They should not be parallel. Next one. So this is the outflow tract. I told you, the 3-chamber view. Pulmonary artery, aorta, superior vena cava. When you put on the color, it gives you that beautiful tick sign. Next one. So this is the cardiomegaly. Again, the heart is pushed to one side. Next one. Aortic arch narrowing. These are the two views that we see. That is the ductal arch and the aortic arch. There is narrowing of the eye. See this, here it is wide, here it is wide, here there is narrowing. When we put on the color also, here there is narrowing. So this you have to follow up every week or 15 days depending upon when you find it, like 7th month, 8th month, every 15 days do the scan and see if this is going to coarctation of aorta. Next one. So here there is parallel, they are not crossing each other. This is LVOT, this is RVOT. Instead of crossing each other, they are parallel to one another. That is transposition of great vessels. Here we see only one dash and one dot. Instead of dash, dot, dot, we are seeing only pulmonary artery and aorta. So they are associated with so many other vessel anomalies whenever there is transposition. Next one. Now we come to the kidneys. We finished the thorax. Now we have come to the kidneys. There is a huge dysplastic cystic kidney. Whenever you see kidneys, they should be ecogenic, and as it progresses, you see a little bit of mixed ecogenicity in both the kidneys. But if there is fluid also, you have to follow up every 15 days to see if the hydronephrosis increases. If there is a obstruction somewhere from the kidney up to the bladder, then the obstruction goes on increasing. In this case, it's not obstruction, it is cystic. Multiple cysts are there. So follow up. If the cyst size increases, it may go on for multiple cystic disorder of the kidneys. Next one. Here it's the ecogenic one. Later on, this will go for oligoamnios and again dysplastic cystic kidneys. Most of the ecogenic kidneys will go for dysplastic cystic kidneys. Next one. Here we can see only one kidney. On the other side, there is no kidney. It's directly adrenal gland sitting over an empty space. Either that kidney is in the pelvis or it is completely absent. So these are usually associated with Wolffian duct and Mullerian duct anomalies. So whenever there is some kidney anomaly, look for even the reproductive tract, as well as whether it is displaced somewhere in the tract from the kidney up to the bladder. It can be anywhere in that place. Next one. Okay, now the extremities. So here it's a clear cut. You can see the femur, knee joint, both the lower limb, I mean fibula, tibia, and at right angles you can see both the feet. If the feet are this way at right angles, it means everything is fine. Next one. So we can see each and every digit of the foot also with the 3D, 4D, the present high-end scan machines. They are so clear. Next one. So both the limbs we can clearly see in the 3D picture. Next one. So these are different kinds of foot anomalies, either varus or valgus anomaly. It's a club foot. If it is internally rotated, it is a club foot. Usually club foot is much more difficult to treat than CTEV. CTEV, if it's milder degrees, only with manipulation, mother is taught how to do it, and strapping of the foot, usually it's get corrected. But club foot, I think it needs surgery as well as a boot and all that. Even shortening of the limb also will be there. Next one. So this is the club foot. In this you can easily make out, because that foot sticks out. When you make a scan, you can easily see that this foot is not normal. Instead of this way, it is sticking out. It has a different angle. It sticks out. It's easy to diagnose whether if you are looking for it, it's very easy. Next one. This was a very interesting case. Mother had her fourth digit almost like it was overriding the third and the fifth digit. She asked me to see if the baby has the same kind of anomaly. So when we looked for it, we were surprised to see it was the fourth digit was like this. It was overriding the third and the fifth digit. It was very interesting. But after the baby was born, next one, it was a very mild variety. Mother had a very severe variety. This one, it was there, and actually the bony one was scary. But to look, this was a milder variety, hardly noticeable. Next one. So fingers, you don't need to count them. At least if at all the baby is opening or closing the fingers, that is very important, because clenched fist is very much associated with trisomy 21, 13 and 18. So if the curling of the fist or clenched fist, usually look for any genetic or chromosomal abnormalities. If the baby is opening and closing, even if there is an extra sixth digit, it doesn't matter. Next one. Next one. So what is radial ray syndrome? Radial ray syndrome is just the equivalent of the club foot in the leg. Here there is absence of the radius as well as the club hand. The baby is always holding it like this. This can be easily diagnosed in the third and the fourth month, and it's almost the baby cannot use its upper limbs at all in this position, and without a radius, even the forearm doesn't allow the baby to use it for any finer movements or coordination. So usually this is a part of Poltarum or Vactral syndrome. So in this case, we usually go for abortion of this anomalous baby. There's no point in continuing. So omphalocele. What is omphalocele? What is physiological herniation and what is omphalocele? The midgut rotation usually happens from 9 to 12 weeks. So if at all you see mild herniation at the umbilicus, you should not take it as omphalocele up to 12 to 14 weeks. Only after 12 to 14 weeks it still persists and it is growing in size, it means it's an omphalocele. Next one. So this is omphalocele and gastroschisis. Which is more dangerous? Yes, because it is associated with genetic as well as chromosomal abnormalities. Though it is covered with a nice covering, this is more scary because gastroschisis is paramedian and is not covered. This is easier to operate. Usually the contents are only bubble. Whereas in omphalocele, it is associated with genetic problems. It is usually, it has a liver as content, and in this we can see from the caudal portion the umbilical cord comes out. Whereas gastroschisis, it is not in the midline, it is paramedian. And if at all immediately the parents take the baby to the pediatric surgeon, if it's operated immediately, this has a better prognosis. Gastroschisis has a better prognosis. Next one. So that is the difference. Next one. In this case, we had to abort the baby because liver was the content. Next one. So Doppler. What are the 3 important Dopplers that we do? First of all, you have to do umbilical artery Doppler, which is very important. So, which is the right place to do the umbilical artery Doppler? Either the free cord or around the bladder. Around the bladder, it is better because the baby is stable. Around the bladder, when you see both the umbilical arteries, one on either side, it tells you that it's a 3-vessel cord. If the it divides into 2 vesical arteries, if there is only one artery around the bladder, it means it is a single cord, single umbilical artery. So you can do 2 things at one time. You can rule out if it is a 2-vessel cord, as well as you can record the umbilical artery Doppler. If there is in the umbilical artery, if the flow, that is the diastolic flow, should be more this way. If it is good amount of diastolic flow, it means the baby is getting enough flow from the mother. Uterine artery Doppler is exactly opposite. That is, the systolic flow is more. There may be a small dicrotic notch here, and then the diastolic flow. This you have to locate both the right as well as the left uterine artery Doppler and take the average to. This is main pointer for impending PIH, pregnancy induced hypertension. You have to do it, say, from 4th to 5th month up to TIFA scans. If at all you see that something is abnormal, then you have to start, see if the patient is already on aspirin, so it has to be continued up to 9 months. Middle cerebral artery Doppler, if at all there is something wrong with the uterine artery Doppler, we see if there is any compensation or brain sparing effect in the middle cerebral artery Doppler. When the uterine artery Doppler, say the end diastolic volume, there is no flow in the diastole, then there is brain sparing effect. So first of all, you have to look for PSV in the middle cerebral artery, especially in Rh negative mothers. There may be anemic baby. So in this we see the middle cerebral artery PSV and then decide if the fetus has anemia and then give a blood transfusion. Next one. So this is absence of the end diastolic flow. This is very important in case of fetal growth retardation. This is how we every week we do this, and then whenever there is end diastolic volume is absent, almost every day or every alternate day we gain map. Next one. If there is reversal of the end diastolic volume, it means there is impending death. In these cases, you have to do an immediate cesarean if you want to save the baby. Next one. So this is GIT anomalies. Here there is a typical double bubble when there is outlet obstruction from the stomach into the duodenum or from the duodenum into the jejunum. In any portion, if there is an obstruction, you can see a clear double bubble, and in these cases, if it is severe, you can actually see the baby vomiting also. Next one. So renal pelvic ileal dilatation, that's what I said. If there is obstruction anywhere from the kidney up to the bladder, this will reflect as hydroureteronephrosis. Next. So here there is a keyhole sign, that is the posterior urethral valve in case of a male fetus. So there is dilatation of the bladder and you can actually see that keyhole sign. Next one. This will lead to any kidney problem. It will either lead to oligoamnios or polyhedram. Usually oligohedram is because that kidney is not functioning or there is an obstruction. So there is a cyst here. How do you know that it's a ovarian cyst or a mesenteric cyst or a bladder cyst, bladder dilatation? How do you know? How do you say, like just now I told you? Put switch on color. Next one. So here you can see that both the umbilical artery, they are dividing around the bladder, which tells you that it's an enlarged bladder. Next one. So in this enlarged bladder, we had this foot also which was sticking out, which means it's a club foot. This was as early as 12 weeks. So at 12 weeks we could see a club foot, we could see an enlarged bladder. Next one. What is this slide? Anyone? So what organ is this? One clue. Tulip sign. Tulip sign. This is the tulip sign, second one. This is the tulip sign. Next slide.
CH, congenital pyloric stenosis, either stomach or antral part.
No, you are right on top. We are somewhere down below. Next one. This is ambiguous genitalia. That's what we keep saying. We should not look at the genitalia because of PCP and DT. We are supposed to look at the genitalia. We are not supposed to tell the patient, but we are supposed to look at the because if the patient comes back and tells us there is ambiguous genitalia, you didn't tell us. We tell them like we are not supposed to see the genitalia, but actually you are supposed to see the genitalia. You are not supposed to reveal the sex. So this is ambiguous genitalia. That is absence of gonads with that star sign is absence of gonads. The tulip sign is where it's like a bifid this thing lips, not whether not sure, even gonads they are not sure whether it is a male or a female one. There is a mega urethra right in the center of that. These are different types of ambiguous genitalia. There is a small hypospadias with the opening down below here. Here there is a distended bladder also with the megalourethra. This is a microurethra. Or different kinds, quite rare, but if at all you find them, then you are supposed to reveal it to the patient. Next one. So this is multiple pregnancy. This was a nice case of trichorionic, triamniotic triplets. This lady was almost 5'9" and she agreed to carry the triplets till term. So we went on with her till term. And at 9th month, I had 2 pediatricians in my OT because 3 kids were there. And it was a nice delivery because all the 3 kids were more than 2.5 kg each. I really don't know how that lady carried because she had a huge tummy, and we went almost up to 38 weeks. Next one. So it was 1 girl and 2 boys, and every year they come and cut the cake in my hospital. Every year, every birthday they'll come to me, they'll cut the cake at our hospital. Next one. This is a case of quadruplets, but it was a pair of momo twins and 1 pair of twins with a dividing membrane in between. So they decided to continue the one with the healthy one, and this one we went for fetal reduction. The momo twins we aborted, the other one we went. Now she's still carrying. Next one. So this is a clear-cut case of momo twins on one side, and on the other side it is a dichorionic diamniotic. Next one. Same thing. Next one. So can anyone tell me what this is? That wide, whenever you see something as big as this, such a huge one and so long, this was I think around 8 to 10 weeks, so it has to be Siamese twins. Next one. Actually this is a video, it's not running. Next one. Next one. So here it is a omphalopatous where the thoracic cavity is, this is the commonest kind of Siamese twins, where the thoracic cavity is shared between the 2 twins. So I think one or the other structures in the thorax and the upper abdomen, there is sharing between the twins. Next one. This is again ascites hydrops in a case of Rh negative pregnancy. Next one. Oligohydramnios, where there is almost, I think we can see only the adrenals, bilateral renal agenesis. Next one. Polyhydramnios. So what is an amniotic band and what is an amniotic synechiae? Which is more dangerous? Sinike, they are flimsy strands from one side to the other, which usually the baby may not just kicks around and goes around, and sometimes they break also. But these are very strong structures. They have their own vascular supply. They are so strong that they can cut through the amputate the baby's digits and sometimes even strangle at the neck also. Next one. Actually, that is one way where you can save yourself in case you have not diagnosed a missing limb and the baby is born with one digit absent. You can always say it may be because of the amniotic bag. This is a 2-vessel cord. Next one. So, umbilical cord and its insertion. This is the normal one, 3-vessel cord coming out from the actual side of the abdomen. Here you can see this is the urinary bladder of the mother. Umbilical cord is going in at the edge. So it looks like it is a marginal placental insertion or a velamentous placenta. You have to be very careful when it is like this, because in case you deliver the placenta first and then the baby, sometimes there will be exsanguination. So you have to be careful whether in these cases it is better to go for cesarean section. Next one. So that is a normal one. Here you see the marginal insertion of the placenta. Usually these cases I have seen, they are very common in accreta and percreta, different kinds of insertion. How do you make out whether it is an accreta? When you see a placenta and the uterine wall, there should be a nice hypoechoic band in between the two. If there is no hypoechoic band, then it means it is inserted right into the myometrium of the uterus. Always be careful if it is in the lower segment. It's better to refer to an institution. Next one. That is a true knot. Not dangerous if it is loose, only if it is tight, and if there is anything wrong with the umbilical artery Doppler, then you have to worry. Even if there are 2 or 3 multiple umbilical cords around the fetal neck, always look for the umbilical artery Doppler. If the Doppler is fine, it means it's not strangulating the baby. If there's something wrong with the Doppler, there is mild decrease in the end diastolic flow, then it means it is strangulating the baby. Next one. There was a cyst just beside the urinary bladder. We looked it up after week, it was still there. But when we tried shifting the mother, even the cyst was shifting from one side to the other. So we had a doubt whether it is inside the baby's fetal abdomen or it is attached to the placenta. Next one. When we delivered the baby, we saw that it was just adjacent to the placenta. Nothing wrong with the abdomen of the baby. Next one. So this is the environment. Now we have finished with the baby. Now we come to the environment. So there's a small fetal pole there with a huge cyst. So follow up this baby, like say around 1 week or so. If it's still continuing, then you will have to go for a laparoscopic removal of the cyst even during pregnancy. Next one. That's it. So these baby expressions, I really find them so nice and exciting. This baby was like this in the 9th month, and after birth it had the same nose and the same lips. Next one. See the baby, I mean 9th month, it's very fun watching them. Different expression, that baby was thinking, smiling. Next one. So see, that baby was drowsy. Next one. See, this baby was thinking with an open mouth. Next one. Different poses, they're so nice to watch. Next one. So this baby was giving me a salute, and that baby was literally saying, "Why are you looking at me so many times?" Next one. This baby was yawning. Enough of scanning. Next one. Next. So recently 4 doctors in Kerala, they were arrested because they belong to different centers also. Both the centers, they had missed quite multiple anomalies in the baby. This baby was born with serious birth defects, facial deformities, malaligned ears and eyes, atypical genitalia, hole in the lungs and tongue retraction, multiple. This baby had so many anomalies, and the parents were quite educated. They went to the court. All these 4 doctors, they had to shell out some amount in crores. So be very careful with your scans. If you are doing a basic scan, if you find something wrong, please refer for a higher end, like say TIFA scan and all that. Don't tell them like it's okay, everything is normal. Always have your TIFA. If something is wrong with TIFA, get a second opinion. Without because missing out extremities and missing limbs, it is a crime. So be careful. Next one. So all said and done, the baby is still, I think it's teasing us and telling us we'll still have so many things underway. Next one, we may miss so many things. This is how it looks, how a baby looks on MRI. That's why we do ultrasound. We don't do MRI because it's so I mean really scary. Next one. Okay. Thank you.